Good afternoon. I'm Dr. Maija Steenari. I like walking. How far can I walk? All right. I'm Dr. Maija Steenari. I'm one of the pediatric neurologists and epileptologists from CHOC around the corner across the freeway. Nice to see so many faces here. Thank you for everybody for coming. I kind of feel silly standing alone talking about team approach. I was just chatting with my nurse practitioner before I walked in. I kind of wanted to bring her in and my keto dietitian and show the support of the team, but I'll try to paint it with words. So as you already parents know from your children, but we also as physicians who take care of these kids, it's not only taking care of that one particular medical problem, like for me, taking care of seizures. There's so many other parts. Perfect. There. Is that good? No? Is that good? Oh, okay, great. Perfect. I have no disclosures. What I'm going to talk about today, I'm going to kind of define what a medical team thinks about. What is a medically complex patient? I'm going to touch on some challenges that are affecting families who live with medically complex children. I'm going to talk a little bit about different models there are in our medical system, taking care of complex kiddos. And then I'm going to discuss a few examples how a multidisciplinary team approach can help, particularly in children who have SCN2A related disorders. So what is a medically complex pediatric patient? So kiddo has a chronic physical or developmental or behavioral or emotional condition that requires significantly increased medical care compared to a typical child. That's defined. That's a definition the Maternal and Child Health Bureau uses. There's also a similar type of definition from AAP, but basically it's chronic medical condition and higher use of medical visits and technologies compared to a healthy child. I wanted to stop there and say you may hear a funny language. I'm not Eastern European. I'm from Finland, so Northern Europe. So that's why I have an accent myself. So hopefully you can understand what I'm saying. I've been here for 22 years, so it's going away. So there are some specific domains that kids with chronic medical conditions have. And I think one of the big domains is what families are telling us. So family identified needs. As you know, having a medically complex child outside of just, doctor visits or co-pays, there's a significant financial burden. For example, my patients or parents who have their own business and because of the several doctor visits need to miss a day of work or not go to do their cleaning or gardening or whatever they do, so they don't get paid from that day. Needing a bigger car so you can fit a wheelchair in there. Insurance is not covering all your needs. Transportation challenges. I have a family that mom has a wheelchair and child has a wheelchair. So mom is like, how can I go to physical therapy twice a week? Doctor, you tell me that it's beneficial for my child, but it's really difficult for me to take my child to PT twice a week or your appointment. So we do telehealth. Specialized educational needs. And it takes a lot of time for you to schedule your GI appointment, your epilepsy appointment, your ortho appointment, your behavioral therapists and school IEP meetings and all this. So your calendar is full and you have to call, and at least in our office, it takes a little while for parents to get through. So you spend a lot of time on the phone waiting for that answer and discussing your concerns. Chronic conditions are typically severe. There's a higher association with morbidity and mortality. Kids with complex medical conditions have limitations on their physical activity. They have limitation on participation. They often require adaptive technology, wheelchairs, walkers, sometimes tracheostomies, tubes, ventilators, braces, and so forth. And obviously healthcare use is big. What is a complex care clinic? It sounds complex. So treating medically challenging children really requires a multidisciplinary approach. Team members can be physicians. For example, in SCN2A related disorders, some common physicians are pediatric neurologists, your epilepsy specialist if you have a child with more refractory epilepsy type, your maybe neurodevelopmental pediatrician or psychiatrist helping with behavioral challenges, your orthopedic physician, your GI, your ophthalmologist, that's we just learned from Dr. Shu. Nursing, your outpatient PMD office nurse, your complex care nurses, your nutritionist. If your child is on a ketogenic diet, you're in a very close contact with your nutritionist. Care coordinators are so important. How do you go to your doctor's appointment and they order VTM, MRI, sleep study, a swallow study, go and see your orthopedic doctor, and you walk out like, oh my goodness, what did I have to remember? The care coordinators help. This is the phone number to call, have you make this appointment that was ordered, or your 6-month visit is coming up. Can we make that appointment? So it's really, really important. Social workers helping with family medical leave, what is out there here in the community supporting you, and whatnot. So the goals for your complex medical care team is maximize your support, facilitate coordination of care. That's one of my favorite things in multidisciplinary team clinics that I attend is we discuss a problem that the child and family has together as a team, and everybody kind of brings their own idea from whatever their specialty is, and then together we can coordinate. Well, yes, child is vomiting, so that is directly a GI issue, but maybe the vomiting comes from the medicine that me as an epilepsy doctor could give, and then we coordinate together a plan and then how to move forward. And if this doesn't happen, please GI doctor do this, or if this doesn't happen, then I will do something else. Communication is a key with your team. Assisting transitions of care, so inpatient to outpatient, or ortho to neurology, and so forth. The goal is also minimize ER visits, to have a plan, minimize hospital admissions, and then be a proactive instead of reactive. So to pay attention to medical issues that a typical child, for example, with SCN2A related disorder can have, and treat it preactively, not just, oh my goodness, now their spasticity and contractures are so severe that we have to do major surgeries, for example. There's different models for complex care. And I'm going to talk about 3 common models. These are all in ideal situation. And You're very lucky if you have one of these models functioning beautifully. The first one is primary care centered. So your primary physician is the center of everything. They are the coordinator of, I know your GI doctor, I know your epilepsy doctor, I know your orthopedic, and we had a team meeting together, and this is the plan. I will follow up, your medications for reflux, I will take care of it, and so forth. These primary care physicians, obviously, the typical 5-minute appointment is not enough. There are some that I've met who actually can spend an hour or two with the complex patient and take the time and coordinate everything. So this is a wonderful model that rarely happens in the US. The second model is consultative model. This is something that I do a lot with my different patient populations. So there's a co-management. You have your own primary care physician in your local community, and then you come to a tertiary center and get your complex care there. And then we collaborate together with the primary care physician. I take care of all the epilepsy needs, but then the primary care physician takes care of vaccinations and regular healthcare visits and whatnot. There's also episode-based model that I think is one of the most common one in US. So you see the experts or subspecialties only when your child is in trouble. In the ICU, you quickly see maybe an epileptologist, they were in status, but then you go and not follow that as an outpatient. It might be there's an acute injury after a prolonged seizure, ischemic injury, or worsening of your baseline. You go to a rehabilitation unit for a little bit, and then you go home and follow up with a primary physician. Sometimes it's short training period, and then your primary care physician takes care of everything else. All right, so this was quickly already discussed by Dr. Olsen, and she said that she will discuss further tomorrow. But just a quick overview of what me as an epileptologist are thinking initially about SCN2 related disorders, but it's not only that, as I mentioned. There's also other comorbidities with children with SCN2 related disorders: autism, global developmental delay, learning difficulties, seizures that I'm interested in, movement disorders like dystonia, chorea, spasticity, dysautonomia that we're gonna hear after my talk. Cortical visual impairment that I just learned from Dr. Shu is an old term, but I still use that. Disrupted sleep is so common. Many of my patients with SCN2 related disorders, we spend like 2 minutes on epilepsy management, and then we talk about behavior and sleep the rest of the appointment. GI, difficulties with oral movements, difficulty with swallowing and coordination of that. I already showed you this slide, but I wanted to put it here again. So with children with SCN2A related disorders, the goal for complex medical care is to maximize your support, minimize your visits. Sometimes I see when I open the appointments in my patient chart, I have to scroll down to another page. There's so many appointments with GI, ortho, developmental neurology separately, to epilepsy, to psychiatry, and then physical therapy and OT and so forth. So when we can at least combine some of your appointments and coordinate to get the care together, it's so much better for the families and also your medical team. All right, so I'm going to talk a few different scenarios on what could a multidisciplinary team be in care of SCN2 related kiddo. So for example, one can have a autism multidisciplinary clinic. There can be an epileptology or sleep physician or both of them in the clinic along with your developmental pediatrician or pediatric psychiatrist, your behavioral therapist, your OT. We always have social work and care coordinators in our multidisciplinary clinics. Even though it's mainly surrounding behavioral symptoms and care, then we can also address the other questions you might have. For example, my patient, this is not nobody in particular. So if I do have some familiar faces in the room, so if you feel like I'm talking about your child, I'm not. I kind of combined them as together. So 10-year-old girl had history of infantile spasms, was treated appropriately in that infant period. And since then has been actually seizure-free. We were able to wean off anti-seizure medications. Main symptoms currently at this stage is autism and behavior. So lots of self-injurious behaviors. But now mom is wondering, you know what? The behaviors have escalated. The sleep is awful, even worse than before. And she's having fluctuation in her appetite. Maybe she's having seizures again. What do you think? So if you just go and see your psychiatrist for your kind of behavioral medications, psychiatrist always says, yes, it must be seizures, go and talk to your epileptologist or child neurologist. And then 2 months later, you tell your neurologist or epileptologist this concern. And then the neurologist is like, no, it's not seizures, go back to your psychiatrist. And then a month later, you go there. But when we can come together as a team and discuss, well, you know what? Me, epileptologist, we just did a 24-hour video EEG monitoring 1 month ago. I did not see any concern for seizure activity. Let's address the behavior. Let's address the poor sleep. And maybe we can find one medication that could target the poor sleep, appetite fluctuation, and behavior together, and then follow from there. So instead of hopping to multiple different doctors several months away, we can address the same in that same setting and have a plan. The other, so some of our SCN2A kiddos go to our complex epilepsy clinics because refractory epilepsy is their main concern. And there, typically the team consists of an epileptologist. We have epilepsy pharmacists, neurosurgeon if we need to, for VNS or resective surgeries, RNS and DBS. We have our wonderful keto dietitians. I hope tomorrow you'll meet Sarah, one of our keto dietitians, social work and care coordinator. So we're seeing a 2-year-old boy, significant severe global developmental delay. He did develop infantile spasms. And now we could not get them under control with high-dose steroids or vigabatrin or sodium blockers, transitioning to almost like a Lennox-Gastaut presentation now. He's already on ketogenic diet. So we're seeing him together with our keto dietitian today. And mom is saying, you know what, we're still having multiple seizures. What do we do? And then we kind of chat how the day is going. And mom is saying, well, you know, he's vomiting a lot. So that's one, actually, the seizures and the vomiting is my main concern. So there has been situations when sometimes a neurologist or epileptologist says, well, you know what, vomiting is not my problem. Maybe you're vomiting all the anti-seizure medications. So maybe let's go and talk to your GI physician so they can take care of the reflux so he can get all the meds down and then come back to me if he sees it. So let's do an appointment in 4 months. All right, so you jump 2 months later, GI, and GI is like, well, that's not my problem. It's the pain that's causing him to vomit and whatnot. So here we are as a team and chat, and my keto dietitian is like, oh, you know what? We started the sodium bicarb just last time because the CO2 was low. So I've had other kiddos who vomit with baking soda. So what time of the day is it again? So we figure that, you know what, it's right after mom gives the baking soda. So our keto dietitian is actually the key personnel on this visit because she can do another type of keto formula, Keto V, that already has some bicarb in it, and we don't have to give the sodium bicarb. So we kind of limit the GI visits and back and forth, and it's actually just changing the medications that helps the seizures don't go away. So then we refer for vagal nerve stimulator. Mom also is missing a lot of work because of this. Kid is having increased seizures, so social work is there to support filling out family medical paperwork and whatnot. So it's really, really helpful to get all of this wrapped up in one sitting and not to be kind of jumped around different specialties. There's also other comprehensive care clinics that could help your child. We do a lot of collaboration with epilepsy and movement disorder team. So I've learned a lot with working together with them. It's not always increasing medications or adding, it's sometimes decreasing. So I know that as an epilepsy doctor, that sometimes some seizure types increase when you're too sedated. So I treat sometimes increased seizures by decreasing medications. But I'm not very comfortable with that with movement disorders. But now I've learned from my colleagues with working in these co-occurring clinics that, you know what, sometimes this medication actually increases this type of movement disorder. Let's just simplify and take stuff off rather than increase. Sleep clinic, we work together as far as combining sleep studies and video EEGs. So then we can tease out, is it a sleep problem, or is a child actually having a seizure and then wakes up several times a night? So teasing that out with combined studies is really helpful. And medication management, we can kind of pinpoint ideas of different medications options and maybe picking something that or choosing something that can help multiple issues at the same time. Sometimes I see these lists of well, this is the GI physician medications, and there's 5, and then my epileptologist gives me 4, and then my movement disorder specialist give me 5. And if we can simplify and further target and combine, it's going to be really helpful. It doesn't always mean that you have to see all your specialties at that same clinic. So don't feel discouraged if you haven't had a huge team of 5 to 10 people together at the same time in the same room. Sometimes that happens, and sometimes it's really beneficial. But sometimes it's also the fact that your team members are used to working together. For example, I do neurometabolic clinic with our metabolic specialists and genetic counselors. So those ideas that I learned from that clinic, I bring to my genetic epilepsy clinic. Even though I'm there alone or with my nurse practitioner, I have learned this multi-disciplinary approach that I can then use to take care of my other children or patients. Your school, your primary care nurses, their medical assistants, your medical therapy units, all of them together, the goal is to help your child. So sometimes even though if it feels like it might be 3 or 5 different visits, but them collaborating together and communicating together is very beneficial.